We're going to learn a little bit about steroids today, the timing of it, that this medicine maybe that we've all learned about in med school and residency has some new controversy about it as well. And then I want to talk to you a little bit about how we're going to implement this maybe better in practice. How can we do better? I'm going to tell you a little teeny bit about myself. I grew up in Omaha, Nebraska, went to Notre Dame for undergrad, Creighton for medical school and residency, and then Chapel Hill, North Carolina. Went from a football fan to a basketball fan in Carolina, and then went to a state that has essentially no sports at all, New Mexico. Anybody visited New Mexico? It's just south of us. Really great place to visit. I worked for a place called Perinatal Associates in New Mexico. Large practice. We have 5 doc offices, 7 satellite offices. We really wanted to bring, kind of like you guys, the best care to the areas, right? You guys go to so many different environments. 5th largest state in the United States, 36th smallest population, probably one of the most complicated states. We have the 2nd highest maternal mortality rate. We need to do better in New Mexico, and we are trying our hardest to do that. We've been in business since 1987. We have 5 docs that work in the practice, 17 nurse practitioners, 30 sonographers, a huge team. We do global inpatient and outpatient care. I don't want to just do ultrasounds. I know you have MFMs that maybe do that. We want to take care of the patient from the start to the beginning to the end. We do a lot of diabetes management, and I know we're not here to talk about mental health, but if you don't have a mental health program in your organization, I would really encourage you to start one. 2021, we saw 100 patients in 2 months. 22, 1,000. Next year after that, 2,000 visits. This year we're on track to do over 3,000 visits. We have 4 psychiatric NPs that help with that. Huge need. I'll just put a plug in there. Why would you want to come to visit me in Albuquerque? This thing. Coming up in October, first 2 weeks, I make no money making a plug for Albuquerque. The world's largest balloon fiesta, spectacular event, 600 to 800 balloonists that ascend every morning. Bucket list, if you've never been in a hot air balloon, this is the place to do it. All right, let's talk a little science. We're going to talk about fetuses and their lungs really, really briefly so I don't put you to sleep. Talk a little teeny bit about history, because that gets us to where we're at today. Talk some studies, because I'm an MFM, love studies, some recommendations, and then some controversies that you should be aware of. Antenatal steroids, you guys have seen this medication. Betamethasone. Is it the most effective medication that we use today to help the unborn preterm infant? It's definitely saved and contributed to better outcomes in innumerable circumstances. It started with some controversy and has an evolving controversy we're going to talk about. This is your boards question if you're a young person maybe taking your ABOG boards. Steroids reduce something called respiratory distress syndrome, RDS. Half of babies get that if they're born under 28 weeks, less after 30 or under 32 weeks. A mentor told me that 32-week babies grow up and go to college. I mean, that's great, but they have a lot of time in the NICU. We need to optimize their time. Respiratory failure, it occurs because of a lack of surfactant. Lung development. There's 5 stages of lung development. The last one finishes at age 2 after the kid's out. This is another boards question for young people maybe taking their boards. There's something called a type 2 pneumocyte that little surfactant comes out of when you hit the mom with steroid. It gets in there and revs up that type 2 pneumocyte to release surfactant and make that little alveoli more compliant, better oxygenation. That's why they do better. But as you see there, as stress cortisol levels decline, so does that helpful chemical surfactant. I'm kind of a history fun. I like thinking about these things. You see over here in the corner, 1972 pediatrics. First study ever presented on this topic. Graham Liggins was initially doing research on fetal sheep. If he gave the mom a dose of steroids, the fetal sheep coming out preterm lived longer. 1 year later, he turned that into a human randomized controlled trial. Amazing. This is the preeminent article for why we use betamethasone today. Same medication, same dose, 24 hours apart, 2 doses. And this is the study. I love the typeset because it's not a PDF. Somebody's typing this on a keyboard. If you look over here, the baby that got steroids in utero between 2 and under 7 days, that word 7 is going to come up a lot today, 3.6% RDS, but if they got placebo, 30%, tenfold reduction. That's why we give it. It works. Liggins said RDS occurs less when mothers receive steroids prior to a preterm birth. Their baby does better. We conclude there's sufficient evidence to do more trials. We always love doing lots of trials, right? So much study. We studied this a lot. From 1972 to 1994, 24 trials, 24 trials, all showing betamethasone effectuates change and improves outcomes for babies. Where are we 50 years later? You guys really know how to pull a great group of people here. I think you've had a current ACOG president, Stella Dantos, right? Amazing. You have had the current president of the Society for Maternal Fetal Medicine, Cynthia Giamfi-Bannerman here. Unbelievable. I'm going to talk about her research because she's done a lot on this particular topic. Where are we 50 years later? I like this ACOG bulletin because it's covered with highlighter, because it's been printed, changed, edited, updated, affirmed, and I guarantee there will be more to this topic after what we talk about today. ACOG says that ACS is probably the most important antenatal therapy available to improve outcomes for the newborn. We'll go through quickly. I know it's a lot of text. 24 and 0 to 33 and 6. If you're at risk of preterm delivery, within 7 days, steroids is indicated. Same thing. This is thank you to Dr. Giamfi-Bannerman and something called the ALPS trial published in the New England Journal of Medicine. 34 and 0 to 36 and 6. Steroids, useful, if given for preterm birth anticipated within 7 days. And also peri-viable, 22 and 0 and beyond. If a family desires full intervention, we should be offering and giving steroids, but only within 7 days. What's the deal with 7 days? Why is this so important? Liggins, 1972. We've kind of forgotten this issue. The medicine only functions for the baby if the mother gets it and then the kid comes out within 7 days. The effect over time goes away. Betamethasone does not just improve RDS. It helps reduce death of a preterm infant, reduces IVH. Nobody wants intraventricular hemorrhage in their baby's brain. It helps reduce infections. Profound impact of these 2 doses, so we need to time it correctly. If you do not time steroids correctly, you are going to have a worse outcome for the baby. You're not going to recognize it, the baby's going to recognize it. The NICU is going to deal with it. As you get farther out, 1 week after, so now days 8 to 14, RDS rates are 3 times higher. If you're out 21 days, 7 times higher. The effect goes away. You hit them with a profound steroid dose, the baby comes out within 2 or 3 or 4 days, wonderful. If it waits forever, not a great outcome for the baby. So you're not helping them. How are we doing with timing? Do you guys think we're doing awesome with timing of steroids? Yeah, this study is one from Canada. 20% of women received optimally timed steroids to benefit their preterm infant. 1 in 5. This is a study broken down by diagnosis. This would be one I would like to point out. Women with no symptoms of anything. Don't give them steroids. They do not need it. The baby's not coming out. But we give it. 40% received optimal timing in this study follow-up in the British Journal. Anybody seen this paper by SMFM 2 years ago? Quality metrics, improving what you and I do to care for patients. This is definitely worth a read. It's a special statement, quality metrics for optimal timing of antenatal corticosteroid administration. SMFM recognizes the same thing ACOG just said. Optimally effective if given within 7 days of a preterm birth. They recognize we do not time this well. Why were we so incentivized to give steroids like crazy? Joint Commission. PCO3 used to be a metric that basically assessed every single hospital in the United States. Did a child that was born preterm in any circumstance, no timing assessed, receive steroids? What'd that make us do? Give steroids like crazy. Decreased fetal movement, better give her steroids. Drop of blood on a pad, better give her steroids. She fell down, she hit her rear, better give her steroids. Does this sound familiar? Triage. You're totally stable, ma'am. I'm going to give you steroids. I'm going to send you home because I do not believe anything is going on with you. And I'm going to have you come back to triage and get a dose of steroids. Does anybody do that? You see that in practice? Yes. Probably not the patient that should be getting the medication because number one, it's not going to benefit the preterm baby because the preterm baby is not going to deliver. We did so well on this. We got an A++, 97%. We'd never achieve these in almost any other circumstance, right? Breastfeeding, squeezy boots for surgery to avoid VTE, antibiotics timed in under 60 minutes. We're not this good. But we were awesome at giving steroids to literally every mom that walked in our triage unit. It's time to change that. This metric from Joint Commission, it incentivized us as clinicians to liberally give this medication. Low rates of optimally timed scenarios, but there's some new things out there that are concerning. We may actually be doing harm to an unborn child if we give this medication in an inappropriate setting and if it's not timed correctly. We may actually cause adverse outcomes. And I think that's what we should think a little bit as a pause button before we say just give steroids. It's not necessarily completely innocuous. There are now concerns about NICU admission, SGA, mental neurocognitive and behavioral disorders in children. And I'll show you just a snapshot. If you go on PubMed and type in like the word antenatal corticosteroids and neurodevelopmental disorders, you'll get about 97 articles now. So this is definitely a growing subject. Associations between antenatal steroids and mental and behavioral disorders. Are newborn outcomes different if they get it preterm and deliver it term? Neurocognitive sequelae for children that receive steroids through their mom in utero. This is the first one, that landmark study that gave this a thought about this topic. Done in Finland, you can argue Europe, etc., but the benefit of this being done in Europe is they have this really cool way of linking the mom's chart to the baby's chart, which we don't have in America, really. We're trying, but we're not quite there. They looked at the active problem list for those kids if they received steroids or not, and when they got them. And they looked from birth to 9 years of age, a large group, almost 15,000 kids got steroids. They're going to tell us the same thing. We're not timing them well because 50% of them delivered at term, and that's going to become pertinent. In the aggregate cohort, if you didn't get steroids, your risk of mental and behavioral disorders, 6%. But if the kid was exposed to steroids in utero, 12%. Increased odds ratio. The weird thing about this is, if you time it correctly, it helps the baby and there's no harm. If you don't, and you give a 24-weeker steroids and she delivers at 39 weeks, this is the issue. They see the effect only in children that have preterm exposure to steroids and are born at term. How often do you think that happens? A lot. 10% of women deliver preterm, right? 7% are related to things that we deal with, PPROM, preterm labor. The other 3% are preeclampsia, growth restriction. I tell them to come out and deliver. We're giving tons of this medication unnecessarily, and then they deliver late. In preterm kids, you give a 25-weeker steroids and then they deliver at 26 or 7 weeks. There's no found difference. People criticize the study because it didn't go long enough. It didn't specify what the diagnoses were. It just was mental and behavioral disorders. So Finland broke it down even further. My wife's a speech pathologist. We kind of talk about I take care of the patients, then we deliver a preterm baby, and then she takes care of the kid and does speech and articulation and reading and learning and things like that. So it's kind of interesting that actually this Finland study included speech and language, scholastic skills, pervasive developmental disorder, hearing, epilepsy, cerebral palsy. Same thing. Smaller but when they carry it further out, but there still is an overall aggregate effect. If a kid is exposed to steroids in utero, they have a higher complication rate up to age 12. And it is seen only when we administer it preterm and they deliver at term. And this included a lifelong scenario called cerebral palsy. That's Europe. Do we have anything in America that says there's maybe some concerns? There's a group out of Indiana, you may have read this article. Our newborn outcomes difference for term babies who are exposed to antenatal corticosteroids. They looked at women coming in for the top maybe 3 reasons somebody goes to triage. Preterm labor. I am contracting. I don't know what's going on. They gave a lot of folks steroids, 5,000 women, 28% got steroids at 32 weeks, half of them delivered at term. Not good timing. But what did it do to the baby? Did it cause any harm in children in Indiana? Oddly, the medicine we give preterm to keep the kid out of the NICU, it actually, if you don't time it well, 12% of steroid-exposed babies went to the NICU versus 6% if they did not get steroids. That's kind of weird. I don't have every answer as to why this is. This is an evolving field, but you all need an awareness of this. I've had patients come now and ask me, Doc, they just gave me a dose of steroids, but I'm not so sure I want the second one because what do? Google. And they're seeing these studies. And then they're thinking, should I have that medication? They also saw that it caused the babies to be too small. And there's good evidence about that. The first few studies in America done on steroids, we knew we weren't good at timing it. So what did we do? We gave it every single week. 2 doses, 2 doses, 2 doses, up to like 12, 14 doses of steroids. You know what it showed? Ron Wapner study. It shrunk the baby's heads. Microcephaly. They caught up eventually, but they never evaluated learning scenarios in those children. And so there's definite concern and thought about this topic. The authors suggest use of ACS for women being evaluated for preterm labor, threatened preterm labor, should be judicious. Don't just throw stuff at them. Do a complete workup, and we're going to talk a little bit about that. You guys had Dr. Jonfi Bannerman here. Totally amazing person. Approachable, brilliant. Last year, SMFM, she looked at the ALPS trial because she predicated why we give late preterm steroids. And we still should do that because in this evaluation of her cohort of children, they looked at 950 of them, not all of them, so that's one critique of the study. But in late preterm steroid exposure, 34 to 36 and 6, there does not appear to be this potential harm. This is an American study. So administration of late preterm steroids did not affect childhood neurodevelopmental outcomes. That's great. There are a lot of articles that suggest otherwise, but this is an American study. And this is the publication because she was quick to write it up and put it in JAMA just this year. We know steroids improve short-term neonatal respiratory outcomes, but they also can increase hypoglycemia. One caveat that I'm sure you hear from your NICU every once in a while. There will be more on that topic as well. But the important one is that late preterm steroids, reassurance for your patients in America, we don't think there is harm cognitively up until age 6. So SMFM, back to that paper, they say we need better prediction tools, right? Probably AI is going to fix this for us all, right? I mean, it's just going to like analyze. We won't know what it's doing. It's just going to say, do this, do not do this. I'm joking. That might come, but today, what could we do? What do we have? How should we be following, looking at patients? SMFM says we should encourage clinicians to actually think about the risk of the fetus coming out in 7 days. Is it going to happen? She has severe preeclampsia. Her creatinine is 1. It's 1.3. She needs steroids. We're delivering her. Okay? Patient, though, flown down on a helicopter that I got last week from Farmington, New Mexico, who had a digital examination, was told that she's changing her cervix, she has a bulging bag of water, and they did nothing else to her, and they wanted to dispo her out to the triage place, so we paid 30 grand, we flew her down to see us, and we evaluated her effectively. And we did this. A patient with preterm contractions and a negative fetal fibronectin, we should do nothing to. It's an old test, we're going to talk a minute about it, but it has significantly good pertinence today because it's a rule-out test. You guys may use other rule-out tests, right? Cell-free DNA. You guys do an amnio on every single patient that walks in the office? No, because you have a great NPV with something called cell-free DNA. Do we take every single patient who has chest pain with a negative EKG and a negative troponin? Do you do a cath on every one of them? No. So there's lots of thought process on this. And SMFM says also, asymptomatic people, don't do anything to them. I love ultrasound. We're going to talk a little bit about cervixes, short cervixes, ultrasound. If they're asymptomatic, we should pause. And this is where you guys come in, and I'm going to have an ask to you. SMFM wants facilities to do projects. And SOGH, I know you have lots of projects. I've read the whole agenda. We're improving teamwork. We're improving safety. We're implementing protocols. We need better protocolization of this, and I guarantee you're all doing this different because I've given a lot of lectures on this topic. So can we work together on this? And that was the plug from Teresa. I would love to help work on trying to do some pilot quality projects on this. Where do we improve? This room, right? You all have one of these. They look slightly different, but they all have the same stuff. Bed, examination equipment. First thing we should always do with a patient is talk to them. What have you had happen to you in your past? I had a 25-weeker, preterm labor. I had a 26-weeker. She's in your triage unit now. She's 26 weeks. What's the probability she's going to do something? 50%. She needs serious evaluation. I'm already getting nervous thinking about her. She's contracting, she's bleeding, assess symptoms. You guys are the leaders in your organizations. Physical exam. Look at the cervix. Check the cervix twice, not once. Cervical change. There's a huge study from Trinity, I don't include it in here, in the Northeast, 37 hospitals. They have implemented a preterm labor protocol. Pre-protocol, less than half of the time women got a second digital examination. Are you ever doing that? Do you skip that part in your organizations? I won't make you raise your hands. But that's striking. We're not even doing a basic exam on a patient who's complaining of contractions. And then we have ultrasound, I love cervical link, and then we have a lab test called fetal fibronectin that is an objective tool. And I'm going to answer this for you. I think we take a seriously haphazard approach to this. If I asked Kaiser Permanente, if I asked Winnie Palmer, if I asked Sutter, if I asked my organization, what do you guys do? There's going to be high level of variance. Do you think you approach every pregnant woman the same way? Always? These type of things, I make it small. We need to use protocols. And there's a lot of them out there. Evaluate what's in your institution and design what works. Do we rely solely on our digital examinations to predict what's going to happen? I would say no, because this is not a great tool. This is a study, it's an old one. If you're 1 centimeter dilated, chance of delivering in under 7 days, 16%. If you're 2 centimeters, you got about a 32% chance, 70% chance no. If you're over 3 centimeters, then clearly, like, we're probably in labor. Most of these people actually deliver, and those are straightforward, and we should do something. Finger digital exam, great, thorough, need 2 of them to see if there's cervical change. Maybe collect a fetal fibronectin test with the speculum, look in there, because spec's really awesome. In 2 seconds, you can tell what's going on. Maybe she's 5 centimeters dilated. Maybe there's meconium. Maybe there's a placenta. That spec is an important component, and I bet a lot of us skip that, and maybe your nurses don't do it either. Grab a quick swab, put it in some liquid, 10 seconds in the posterior cul-de-sac, send that, the liquid gets tested, not the swab. 23 minutes later, you have to rush your lab, but it sits on the analyzer for less than 25 minutes. If it's negative, there is a 99% chance that patient's not delivering in 14 days. Don't do anything to her. She doesn't need anything. Reassurance. They love objective information. I get consulted so many times for this, and I come in, we do an exam, we do an ultrasound, we grab all the components, we do a fibronectin, and then I relay the information to the person, and she is relieved. Instead of, she's been checked 7 times. She was 1, then she was closed, then the nurse came and she was 2. I mean, this never happens, right? There's no variability in digital examination, right? I mean, even among ourselves, the intra-observer variability for a digital exam is very high. A couple tests are better if you're going to choose to do something to a patient. The rule out, if that FFN is negative, I'm not doing anything to that patient. But if it's positive, then I really would like to see what this cervix is doing. And that's where you get 2 abnormal tests, and then you get a higher PPV. That's when we make a decision to do something to the patient. Again, what do you see happening? You can think about it. My guess is high variance. This is a study from the Netherlands. The Netherlands, they did cervical length on every single patient that showed up with preterm labor. They realized that it was not great just doing cervical length on everyone. And they said, we probably should make this better. So they implemented fibronectin testing in that strategy. But they didn't always tell the clinicians what to do. And this is a behavior thing, right? We're always tempted. Someone calls you. The nurses always love calling, right? Calling, and what do? You never say, don't do anything. We always give something. So pause and think about it. Cervical lengths over 30 millimeters, widely accepted. That's a normal cervical length. Her chance of delivering in a week, 1 in 100. How many people got steroids? 1/4 of them. Not great Monte Carlo odds. Don't give her steroids if the cervical length is normal. But in the Netherlands, they still were. Behavioral change. We look at the data. We also have to change what we do. You guys would probably argue this area, under 30 millimeters down to 10, this kind of equivocal zone. They did that fibronectin when it's under 30 millimeters, and it was negative. Chance of delivery in a week, 3 out of 100. Nearly 2/3 of women got steroids in the Netherlands. They're not listening to their own data and research. So we can learn from this. Really short, positive fibronectin, now we're at 20%, they're 100%, and extremely short cervix with nothing, no lab test, very high compliance. Those last 2 groups are the ones we probably should be giving steroids to. If you do a cervical length, please know what you're doing. My sisters are there radiologists in the room? Okay, good. Whew. My sister's a radiologist. She has given me permission to give radiologists grief. I want you to think about it. Who does your cervical links in your hospital? How many are done by radiologists? They're done by you guys? All OB-GYNs? No person from radiology ever comes up and does a cervical length. Time of day, right? 8 to 5, you got MFM, you got the OB, but after hours, what do you have? You get a BPP score of 5 out of 8? Yeah, I've never heard that. I don't know why we don't do 5, but we get 2, 4, 6, 8, 10. But that's radiology. They really don't love obstetrics. It scares the dickens out of them. If you do a cervical length, does that look normal? If it's curved, it's essentially normal. So quick take, beautiful. How long do you look at this? 30 seconds. Quick. Nobody wants a long vaginal ultrasound, right? Supposed to look for 3 to 5 minutes. What comes in 5 minutes, do you think? Contractions, because she's there for preterm labor. So this is minute 0, minute 1, and minute 2. She's funneled. She has a U-shaped funnel. And her cervix is now straight and short, 5 millimeters. And she's got some stuff right down here called sludge, debris. We have great words in medicine. Roberto Romero has his fellows put a little teeny catheter in here and suck this out and analyze it for microbiome stuff. Bacteria, white blood cells, fetal skin cells, all kinds of gunk. It's not good. It just sits there. So it's kind of a bad sign. The U-shaped funnel also is a bad sign. So do it correctly if you're going to do this, please. And if you have radiology doing it, we should train radiology. You should help train radiology. Fetal Medicine Foundation is the only organization that has a circumstance on this topic now. Clear from Perinatal Quality Foundation, it's gone. So FMF in Europe's the only way you get certified. What if you put things together to help you? I like using more information versus less. 2 tests always better than 1. Should I give a patient steroids? So her cervical length's under 30. I'm always grabbing a fibronectin. If you come over there and say, you look at that little arrow, it says 44.7% delivery in 7 days. If it gets really short there, that 15 millimeter and under, 75% with a positive fibronectin are going to deliver. These are the patients that should be getting steroids. Not if they have a negative test. You guys ever have people just get admitted? They wait for the next day? I love rounding so much. Usually on like holidays are the best, where my partners maybe they saw some lady with a short cervix in the office and she was not even complaining about anything, but we saw an incidentally short cervix and we investigated it. And now she's in the hospital and she doesn't really want to be there. And you don't really want to be there with her either because it's just documentation, documentation, documentation. Can we have the patient go home? She's got an under 10 millimeter cervical length. I mean, that's crazy short, right? Cynthia Giaffi-Bannerman, another article. Follow up on your, I don't know what you call them, ours is maternal special care rounds, antenatal rounds, high-risk rounds, MFM rounds. She's got a really short cervix. You collect a fetal fibronectin and it's negative. Look at the NPV over there by the arrows. 0 deliver in 14 days. I love telling patients this. It gives them confidence to go home because they get stuck there and then we don't want to send them home, right? Here's another article by Sean Blackwell, former president of SMFM. Are we using the tools that we have? Here's a 5-state database, large insurance number, 23,000 women that show up in your units for preterm labor assessment. What are we doing to them? 76% are discharged home. So a lot of people are going home. Most of them deliver much later. Did I tell you that when you do a fibronectin, 80% of them are going to be negative? 20% positive. That's from the original study by Peaceman in the New England Journal of Medicine. It's kind of funny. Here's 80%. So every one of these ladies probably got a fibronectin and was sent home. but 1 in 5 of them come back and deliver in 72 hours. So what did you do to this person? Maybe it's your sister, your daughter, your loved one that went to triage at 25 weeks, she's contracting. What did we do to her? 80% of patients in this national US study had nothing done, no objective test. Not a fibronectin, I know we all love ultrasound, nor an ultrasound. This is where you can help us change this. We need to treat patients better. We think we're doing it, but when we put it in an aggregate form, we are not. We are failing patients as they come in to see us. I just showed you about 10 articles that show that these two things, ultrasound and fibronectin, when used together, work very well. 1 in 100 people that delivered in 3 days, you saw them and they came right back. Wonder if they got steroids. It didn't evaluate that in the study. So pick whatever protocol, just give it some thought. What's your organization like? Do you have ultrasound? Are they certified? Do you have a lab test? That can be, you can talk to the lab director. Every time we send a fibronectin, it's going to be stat, because I want the result. We want the turnover. We don't have enough nurses, right? Huge staffing shortages. Can we get the patients in and out faster? If you have unreliable ultrasound, I would argue these two objective results, a negative FFN or a positive, will help you. Don't be afraid of the positive. 1 in 5 chance you're getting it. Do an ultrasound for that person. Do you love doing an ultrasound on every single person? You can do it all if you want, but if you don't have reliable ultrasound evaluation skills, FFN really should be right there. If you do, the benefit is really under 30 millimeters. There's a lot of different organizations that have said 25 to 30, 20 to 30, 15 to 30. Under 30 really is where the sweet spot's at. Because if it's 8 millimeters and she has a negative fibronectin and she's really not doing much, I just showed you a study where she's not going to deliver, she doesn't need to be admitted, and she probably does not need that medicine, that steroids. So how can we improve? We need a study. And I love talking because I'm a guess is maybe you hadn't heard all this about steroids and some of the controversy. Think about what we're doing to the patient before we just say give steroid dosing, and use the tools. We have them. I have no doubt we'll have better tools in the future, and maybe AI will fix it all for us. But we also need to follow the protocols and trust the test results. You never do something to a patient that has a normal EKG and a normal troponin. Why are we doing something if they have a negative fibronectin and a normal ultrasound? And our societies, I'm sure SOGH has lots of different protocols and guides for you. If you don't have one specific to this, we should develop one. And ACOG wants us to do this. Whatever path we pick, checklists and protocols make a profound impact on how we take care of patients. Steroids, definitely the most important medicine that we have available today. It's 50 years old. We're going to learn a lot more about this. SMFM last year, 20 plus articles about steroids and adverse effects. We need to improve the timing. Can you guys on the front lines, in triages, in OB/EDs, can you make an impact on that? Don't give it to patients that are going to deliver at term. And if you never read this book, I'll end with this one. Atul Gawande is a spectacular person. If you ever have had a chance to hear him, he's a great speaker. We're obsessed in medicine with having great components, the best drugs, the best devices, the best specialists. But we don't pay any attention about how to put them together. We have really complicated environments. Some of you have OB/EDs, some of you have triages. Sometimes their patients are evaluated in your emergency room, the worst place a pregnant lady could be evaluated for preterm labor or anything. We need to assess these and make things fit together better.